My hematological topic will look close at diseases which can be picked up by abnormal values of light chains in the blood, and also will explain the importance of light chains ratio for the diagnostic measures and investigation. So let's start with the clinical scenario. 70-year-old female had her routine investigation done by her GP for recently diagnosed osteopenia. Incidental laboratory findings show raised light chains, Kappa and Lambda, but normal light chain ratio. The question is, does it mean she might have MGUS? To be able to answer this question, we need to understand why light chains are raised and why do we calculate the ratio. Also, what tests need to be performed to confirm diagnosis of MGUS? Firstly, reviewing hematology result, we can see mostly normal parameters. Only platelet count seems to be raised compared to his previous values. Biochemistry results show mildly raised urea and significantly raised Kappa and Lambda light chains. GP requested protein electrophoresis, of which result show only abnormal IgM level. Coming back to the finding values, what are the normal values for light chains? I would like to highlight the Kappa-Lambda ratio, which should be between 0.26 and 1.65, as I will come back to it later. Just to help us orientate within the blood cells, let's remind ourselves the hematopoiesis. The light chains are produced by plasma cells, which are derived from lymphoid stem cell line. Plasma cells develop from B lymphocytes in secondary lymphoid organs such as spleen and lymph nodes after stimulation by an antigen. These cells play a significant role in the adaptive immune response, being the main cells responsible for humoral immunity and producing specific immunoglobulins. Immunoglobulins are a form of heavy chains and light chains, which are bound to the heavy chains. During inflammation or infection, plasma cells produce more immunoglobulins as well as extra light chains which are released into bloodstream, and they are called free light chains. If the amount of free light change is higher or lower than normal, it can suggest a disorder of the plasma cells. At this point, it's very important the Kappa-Lambda light chains ratio, which helps the differential diagnosis, as it's either within the normal range or out of range. Typical clinical conditions represented with normal Kappa-Lambda range could be inflammation, infection, autoimmune conditions, or even renal impairment. On the other side, abnormal Kappa-Lambda ratio may represent the clinical pathologies classified as plasma cells neoplasms, which produce monoclonal immunoglobulins. The clinical conditions, which is represented with Kappa-Lambda ratio out of the normal range, is MGUS. This brings us back to the initial question whether there is an evidence that a patient with our clinical scenario can suffer with MGUS. So what MGUS is? MGUS, or monoclonal gammopathy of undetermined significance, is a benign condition. MGUS does not cause any symptoms and is usually diagnosed incidentally when tests are performed to investigate other problems. Current guidance recommends that MGUS is actively monitored but not treated. MGUS patients are usually checked every 3 and 4 months for the first year following the diagnosis. The checks can be reduced to every 6 to 12 months as long as no symptoms develop. We still don't know what causes MGUS. However, we know the risk factors which can contribute to developed MGUS, such as age is more common in older people, it's rare in people under the age of 40. Ethnicity, MGUS is more common in black people than in white people. Gender, MGUS is almost twice as common in men than in women. Family history, people who have a close family members with MGUS have a slight increased risk of developing it. Or autoimmune disease is a risk factor. Autoimmune diseases cause the body's immune system to attack healthy cells, which we know. Some autoimmune disorders may slightly increase the risk of developing MGUS, such as lupus or pernicious anemia. In patients, the chance of MGUS causing problems in their lifetime is so small, no checks are needed. But it's still important to monitor any of these symptoms. New or constant bone pain, different infections one after another when antibiotics are required, feeling short of breath, extreme tiredness, unexplained weight loss, night sweats, or new lumps or swellings. Small number of patients with MGUS can progress to myeloma or lymphoma. Therefore, it's important to keep regular blood tests. We need to bear in mind there are more serious clinical conditions represented with Kappa Lambda abnormal ratio, such as smoldering myeloma, active myeloma, solitary plasmacytoma, or amyloidosis. Smoldering myeloma is an asymptomatic form of myeloma. Patients are usually only monitored and may be treated by bisphosphonates. Active myeloma is the symptomatic disease which requires immediate review by a hematologist. It's generally now accepted that all myeloma patients have had MGUS first, whether it was identified or not. Solitary plasmacytoma is a tumor made of plasma cells together in one lump. The areas of plasmacytoma are similar to the areas of plasma cells found in people with multiple myeloma. More than half of people with bone plasmacytoma go on to develop myeloma later at their age. Solitary plasmacytomas are most often treated with radiation, but sometimes may require surgery as well. Amyloidosis is a rare condition. Plasma cells make an abnormal protein called amyloid. The amyloid collects in body organs such as kidneys or heart and gradually causes damage of these. Coming to the end of this presentation, let's go back to the tasks related to our clinical scenarios and hopefully we'll have the answers. How do we reply to GP who concerns based on the blood test which was given to us? So now we know the ratio of body light change is within normal limits and there is no evidence of MGUS. So there is not really a reason to follow up blood tests because the rest of the blood is completely normal and the patient didn't present with any red flags. Further investigation are needed for the patient and thus she need to be referred to hematology. To be 100% sure, we need to rule out neoplasms and to complete diagnostic evaluation which include the urine and serum protein electrophoresis, immunofixation to determine amount and type of immunoglobulins, urine free light chains analysis, complete skeletal survey to assess for the presence of lytic lesions, and not to forget a bone marrow biopsy to determine the percentage of clonal plasma cells and potential cytogenetic analysis. What is the most likely diagnosis based on the laboratory findings of the patient and everything which was said today? Considering the age of the patient with osteopenia, raised urea and decreased EGFR, a normal kappa lambda chains ratio with elevated light chains, these are more likely associated to level of kidney insufficiency or chronic kidney disease. Attention, and I hope you enjoy my presentation in Miro, and feel free to give me the feedback below.